Late one quiet evening, Alex, a 35-year-old chemical analyst, faced a perilous situation in his research laboratory. While deeply engrossed in an experiment with potassium cyanide, an unforeseen containment failure suddenly occurred, releasing a lethal plume of cyanide gas into the air around him. Despite the immediate triggering of safety protocols, Alex had already inhaled a significant amount of the toxic vapor, marking the beginning of a critical and life-threatening ordeal. The exposure, purely accidental, was the result of a procedural error combined with an equipment malfunction during the handling of the potassium cyanide. Alex, diligently following the experiment's protocol, found himself caught in an unexpected release of cyanide gas, a scenario for which no amount of preparation could have fully safeguarded him. With the incident unfolding late in the evening, the laboratory's usual hustle and bustle had dwindled to a mere handful of staff, leading to a delayed emergency response. In a desperate attempt to mitigate the effects of the exposure, Alex managed to activate the lab's emergency decontamination shower. It was here, in the aftermath of the containment failure and amidst the activated safety protocols, that the emergency response team found him. The transformation was rapid. Alex went from alert to distressed in mere seconds. His initial coughs, a reflexive attempt to clear his lungs of the toxic intrusion, quickly escalated to gasping breaths, each one a visible struggle against the cyanide's suffocating grip. Confusion clouded his eyes, replacing the usual sharpness with a glazed, distant look. It was as if the very oxygen he fought so desperately to inhale offered no relief, his body betraying him at every turn. Realizing the gravity of the situation, panic took a backseat to purpose. Patrick aided Alex to the emergency decontamination shower, a futile attempt to wash away the invisible foe before dragging him, now semi-conscious, to his car. The drive to the hospital was a blur, a maddening race against time, with Alex's labored breathing filling the car, a stark reminder of the ticking clock. Every second was a thief, stealing away his vitality. Rushing Alex into the emergency department unveiled the gravity of our crisis, prompting an immediate and intense response from the medical team. Witnessing his critical state induced a deep fear and helplessness as I watched my friend fight for his life. Upon Alex's emergency admission to the hospital following his exposure to cyanide gas, his condition was dire, emphasizing the lethal potential of the chemical he had inadvertently inhaled. The medical team sprang into action, their quick response guided by the severity of his symptoms and the critical laboratory findings. Upon arrival to the ER, heart rate was elevated at 135 beats per minute. Blood pressure was alarmingly low at 85/50ths millimeter of mercury. Respiratory rate was rapid at 34 breaths per minute, and oxygen saturation was at 88% on room air, indicating significant respiratory distress and systemic hypoperfusion. Arterial blood gas analysis showed a pH of 7.1, partial pressure of carbon dioxide of 28 millimeter of mercury, and bicarbonate levels at 15 milliequivalents per liter, with an anion gap of 20 milliequivalents per liter, highlighting severe metabolic acidosis. Serum lactate level was 10 millimoles per liter. This level indicated profound cellular hypoxia. Electrocardiogram demonstrated sinus tachycardia, nonspecific STT wave changes, and signs of myocardial oxygen starvation. Initial management. High-flow oxygen was immediately administered via a non-rebreather mask to combat hypoxia, and intravenous fluids were initiated to support blood pressure. 5 grams of IV hydroxycobalamin was given promptly, followed by 12.5 grams of IV sodium thiosulfate to neutralize the cyanide and facilitate its renal excretion. An infusion of sodium bicarbonate was started to correct the severe metabolic acidosis. Due to worsening hypoxia and hypotension, Alex was intubated using RSI protocol with etomidate and succinylcholine, ensuring airway protection and mechanical ventilation support. During hospitalization, Alex developed acute respiratory distress syndrome, a critical condition requiring careful ventilator management with lung protective strategies. This complication was likely a consequence of the initial hypoxia and the inflammatory response triggered by the cyanide poisoning. Over the first 24 hours, his blood pressure required the support of vasopressors, with norepinephrine initiated to maintain mean arterial pressure above 65 millimeters of mercury. His heart rate fluctuated but generally remained elevated, requiring careful monitoring and management. Serial ABG analyses showed gradual improvement in acid-base status, with bicarbonate infusion adjusted according to serial ABG results to correct the acidosis effectively. Lactate levels, initially peaking at 10 millimoles per liter, began to decrease, reflecting a successful reduction in metabolic acidosis and a response to the antidotal therapy. Over the next 24 hours, Alex's condition showed signs of improvement. His lactate levels decreased to 2 millimoles per liter, indicating a significant reduction in metabolic acidosis. Continuous ECG monitoring showed resolution of the tachycardia and STT wave abnormalities, suggesting improved myocardial oxygenation. By 48 hours post-admission, Alex's clinical status had stabilized sufficiently to consider weaning him from mechanical ventilation. Cyanide poisoning is a potentially fatal condition that occurs when cyanide, a highly toxic chemical compound, inhibits the body's ability to use oxygen at the cellular level. Cyanide's toxicity mechanism centers around its effect on cellular respiration, particularly its action on the enzyme cytochrome C oxidase, also known as complex IV, in the mitochondrial electron transport chain. This detailed discussion breaks down the process and consequences of cyanide's toxic effects. Mechanisms of toxicity of cyanide include inhibition of cellular respiration and impaired ATP production. Cyanide can cause cytochrome C oxidase inhibition. Cyanide binds with high affinity to the ferric ion in the heme, a 3Qb center of cytochrome C oxidase, a key enzyme in the mitochondrial electron transport chain. This enzyme is critical for the final step of electron transfer to molecular oxygen, facilitating the production of water and enabling the proton gradient required for ATP synthesis. Cyanide's binding prevents oxygen from accepting electrons, halting cellular respiration and ATP production. Cells rely on ATP for energy to perform vital functions. Without ATP, cellular processes rapidly fail, leading to cell death. The lack of energy disrupts the sodium-potassium pump and calcium homeostasis, leading to cellular swelling, dysfunction, and necrosis. Systemic effects and symptoms include tissue hypoxia, lactic acidosis, and cardiovascular effects. Despite normal oxygen delivery to tissues, as evidenced by normal arterial oxygen saturation, cells cannot utilize this oxygen, leading to histotoxic hypoxia. This results in a rapid onset of symptoms such as headache, confusion, tachypnea, and eventually loss of consciousness. The inability to use oxygen in cellular respiration forces cells to rely on anaerobic metabolism, leading to an accumulation of lactic acid. This accumulation results in metabolic acidosis, a decrease in blood pH, and an elevated anion gap, further complicating the clinical picture. ATP depletion and cellular dysfunction also affect the heart and vascular system, leading to arrhythmias, myocardial depression, and vasodilation. These effects can manifest as hypotension, bradycardia or tachycardia, and ultimately cardiovascular collapse. The diagnosis of cyanide poisoning is often clinical, based on exposure history and rapid onset of symptoms. Laboratory findings, such as elevated lactate levels and metabolic acidosis, support the diagnosis but are not specific to cyanide toxicity alone. Treatment focuses on rapid administration of antidotes that either convert cyanide into less toxic forms or bypass its inhibitory effect on cellular respiration. Choosing the right antidote for cyanide toxicity depends on the resources available at your healthcare institution and the patient's clinical condition. While hydroxycobalamin is favored by many providers for its ease of administration, its availability might be limited by cost concerns, leading to scarce supplies in some hospitals. Therefore, familiarize yourself with the antidotes your hospital stocks and weigh the advantages and disadvantages of each option, letting the specifics of your patient's clinical presentation guide your treatment choice. Amyl nitrite, once used for cyanide poisoning through inhalation, has fallen out of favor due to its short half-life, risks of underdosing or overdosing, unpredictable methemoglobinemia levels, and potential for provider exposure. It was administered by crushing pearls and repeatedly applying them under the patient's nose for 60 seconds over approximately 5 minutes. Meanwhile, sodium thiosulfate aids in cyanide detoxification by providing sulfur atoms for rhodonese to enzymatically convert cyanide to thiocyanate, a non-toxic compound excreted in urine. Sodium thiosulfate provides sulfur atoms for rhodonese, facilitating the conversion of cyanide to less toxic thiocyanate, but it introduces a significant sodium load due to its hyperosmolar nature. The recommended dosage is 50 milliliters, 12.5 grams IV for adults, and 1.65 milliliters per kilogram up to 50 milliliters 9.4 for pediatric patients, administered over 10 to 30 minutes. Common adverse effects include nausea, vomiting, prolonged bleeding time, and hypotension. Sodium nitrite works by forming methemoglobin, which has a higher affinity for cyanide than cytochrome oxidase, effectively diverting cyanide from its toxic pathway. It is administered IV over 2-4 minutes with an adult dose of 10 milliliters, 300 milligrams, and a pediatric dose of 0.2 milliliters per kilogram, 6 milligrams per kilogram, up to 10 milligrams, 300 milligrams. Dosing adjustments may be required for pediatric patients with significant anemia, with the provided dosing being safe for a hemoglobin level of 7 grams per deciliter. However, its use can lead to adverse effects such as excessive methemoglobinemia and potent vasodilation, which can cause transient hypotension and tachycardia. Hydroxocobalamin, marketed under names like Cyanokit and Hydrocobex, is a metalloprotein used for cyanide poisoning, effectively binding cyanide to form cyanocobalamin. Adults typically receive a 5 IV dose over 15 minutes, while pediatric dosing is 70 milligrams per kilogram up to 5 grams IV. Adverse effects include allergic reactions, transient red discoloration of skin, mucous membranes, urine and secretions, moderate blood pressure elevation, and potential renal injury. The blood pressure increase may benefit hypertensive patients, but the red discoloration can interfere with lab studies and hemodialysis for up to 2 weeks. Acute renal injury has been reported with its use, necessitating close monitoring of renal function for 7 days post-administration. A retrospective study linked acute kidney injury to hydroxocobalamin in smoke inhalation victims, suggesting a need for further research. Research primarily uses swine models to study acute cyanide toxicity. One key study compared IV hydroxocobalamin with sodium thiosulfate against IV sodium nitrite with sodium thiosulfate. Finding the former resulted in a quicker return to baseline mean arterial pressure (MAP) without differences in mortality, serum acidosis, or lactate levels. Another study showed that sodium thiosulfate alone was ineffective against cyanide-induced shock, resulting in 100% mortality. Hydroxocobalamin alone reversed cyanide-induced shock in severe toxicity cases, and adding sodium thiosulfate to hydroxocobalamin showed no additional benefits in mortality, hemodynamics, or biochemical markers. There are no published studies directly comparing the efficacy of IV hydroxocobalamin against the combination of IV sodium nitrite and sodium thiosulfate. Alex's encounter with cyanide poisoning underscored the critical importance of rapid identification and treatment of toxic exposures. The swift administration of specific antidotes, along with aggressive supportive care, was pivotal in his recovery. This case highlights the challenges and complexities of managing severe poisoning cases, emphasizing the need for vigilance, prompt decision-making, and a comprehensive understanding of toxicology in emergency medicine. Please click subscribe and the bell icon to keep updated with new videos from the Medical Toxicology channel. And if you have any questions or feedback about this video topic, please comment below. Thanks for watching. Take care.